Our final speaker for today is Professor Willem Alffenaar, who's the chair of clinical pharmacy at the University of Sydney and also at Westmead Hospital. His research interests include investigating the use of anti-tuberculosis drugs as well as the clinical application of, as we've discussed a lot so far, therapeutic drug monitoring. And he has developed implementation strategies for TDM in different settings, and making the best use of analytic techniques and using a targeted approach to individualized care. So I might, that's an ominous sign, but we'll just get on with it. So Willem, please take it away. Thank you.
I'll start sharing my screen. Thank you for the kind introduction. And I was tasked to talk about the role of pharmacogenomics for precision dosing in the critical care. So when I started thinking about this, I always go to PubMed and try to find the latest, newest, hottest article on this topic. But when I actually typed critical care and pharmacogenetics, PubMed proposed to me, please talk about critical care and pharmacokinetics. So there were very few hits actually talking about genetics. So I hope I'm still able to give you a good idea about this application of monitoring in our attempts to optimize treatment in our most sick patients. So if we talk about pharmacogenetics, they were talking about the influence of genetic factors on drug response. And we can actually subdivide it in two main themes, and one is related to pharmacokinetics. When the genetic factors have an effect on drug absorption, drug metabolism, or excretion, but also if you're looking at drug targets that may be a little bit different due to genetic mutations, and then a drug may not work as we expect them to work. And that, of course, may have effect on treatment outcome or side effects of the drug. So ideally, what we would like to do is use an individual's genetic profile to optimize drug prescriptions, prevent toxicity, perhaps select patients who may respond best to a particular drug, especially if we're talking about really expensive drugs or drugs that may cause side effects if they're not effective. And again, if there are opportunities to use these genetic profiles to predict risk of mortality. So if we're looking at the effects of the genetics on the drug metabolism, I think this is a very nice slide published more than a decade ago, but it's still very useful, showing what happens to the drug concentrations in the different settings of poor or fast metabolizers. So when we're talking about poor metabolizers, we have most of the parent drug available and only a slight sliver of your metabolite. And when we move through extensive metabolizers to ultra-rapid metabolizers, those concentration profiles completely reverse, where we have very few parent drug available in ultra-rapid metabolizers and a large portion of the metabolite. And depending on whether the parent drug is active or the metabolite or both, or which of the both compounds cause toxicity, that may have an effect on what's happening actually in your patient. Of course, there are challenges because it's critical care. And one of the most important challenges is the challenges related to the infrastructural situation. We need to have those results fast. And the other thing is when we have these results, we need to know how to interpret those results. And if we're looking at the evidence, and I just showed that there are very few papers on pharmacogenetics in the ICU, can we use evidence generated from, let's say, non-critically ill patients and use that information to guide our prescribing in critically ill patients? Because we know we have other factors that also may impact on drug exposure in patients or response to drugs. Let's say we have sepsis, we have poor or high renal function, we have hepatic failure, we have a variety of drug-drug interactions, and these compete for the effects of the drug in treatment. So fortunately, we have a group of very bright people who try to help us in making use of this pharmacogenetic information, and they're called the Clinical Pharmacogenetic Implementation Consortium, and they have a very nice website which I can highly recommend. You can see the URL at the bottom of this slide. So they do develop guidelines, and when you move over the website and look at the guidelines, they have the drug, they have the gene, and also they look at the level of evidence regarding that particular drug gene combination. And I think this is also highly relevant with respect to implementation of these suggestions regarding drug dosing. And of course, it's a level of evidence that we see across many other fields as well. We have evidence with high recommendations and evidence with weak recommendations. And depending on the situation of that particular drug and gene, you can make use of that. Also, FDA has created a website where they present the information on pharmacogenetics that is included in their product descriptions. And the nice thing is that you can scroll through that website and export as Excel and organize it in your own way. So I selected infectious diseases from this website and found that there are 37 drug gene pairs in that category. And if you look at the most frequent ones, it's G6PD, interferon relation to the antiviral treatments, and only a very few CYP interactions were noticed. When we have that information, in this case from the guideline committees, we would like to use that information for drugs that we use on day-to-day basis. And in this paper published in Pharmacology in 2018, they reviewed commonly used drugs in the ICU, like analgesics, sedatives, antifungal drugs, cardiovasculars, etc., and looked whether they could design clinically actual flowcharts. And I just picked one like voriconazole, and you can see here we have the metabolism through CYP2C19. We have the various polymorphisms from ultra-rapid to poor metabolizers. And depending on the specific polymorphism, there is a clear advice what to do. And if we follow, for example, poor metabolizer, the question is whether that is considered the most appropriate agent for the patient. If yes, then consider lowering the dose. If no, maybe switch to another drug. And same situation for ultra-rapid metabolizer. So these are very helpful suggestions to guide your daily practice. In this other paper, they produce a long list of many other genotypes in relation to specific drugs that may be used in ICU. But when I reviewed this long list of various drugs, and I take the example of analgesia and sedation, and that we have routine scales to assess the level of sedation, and based on that assessment we will adjust the dose for an individual patient. And that of course takes into account the underlying polymorphism of that drug metabolism enzyme as well. And of course you can consider that when a patient is a rapid metabolizer, that titration may take a little bit longer, while if there is a slow metabolizer, you may achieve your effect a little bit earlier. And in some cases, you may see a little bit of side effects early on during therapy. Another situation is when we look, for example, in drugs that are routinely monitored through TDM. that we may reach these targets quicker if we can appropriately use a starting dose that fits that particular polymorphism. So when we consider to decide when pharmacogenetics could fulfill a role in the ICU, I think there are a few items that we can consider. So first, for drugs where there is no routine titration based on effects, for drugs where there is no routine TDM based for variability in exposure caused by renal function, for drugs where we do TDM, but when we know there is a ultra-rapid metabolizer, we know that we will never hit our target, or it takes too long to actually achieve that target in a relevant time frame in relation to the disease. Last but not least, I think very important is if we have a genotype that is related to severe or irreversible side effects, that is something that we could really benefit from by preventing that treatment from prescribing. So an example from literature is the genotype related to aminoglycoside-induced ototoxicity. There is some older literature data from early 90s that a particular polymorphism is associated with a higher ototoxicity. It's not frequently present, so only 1 in 500. But if you consider this in younger children and you can prevent a lifelong deafness due to this polymorphism, it could be worthwhile to further explore prospective genotypic testing. So this was described in this nice study protocol, and in patients with that particular polymorphism, they would change their initial treatment from benzylpenicillin and gentamicin to cefotaxime. So they followed the study up and they did all the nice genotyping throughout their cohorts, and they were able to identify babies with this polymorphism, but more importantly, they actually were able to prevent aminoglycosides from being prescribed to these babies. And also the time to initiation of therapy, in case we do the genotyping and so waiting for the result and selecting the other drugs, there was no difference in time to start of therapy, which is of course very important in relation to treatment outcome. There are a few things that were also considered in relation to as selecting the drugs, and that depends on the need for the use of that actual drug. And they nicely categorize that in various clinical scenarios. So when there is an alternative available, it's easy to select that alternative. But on the other hand, when that particular drug, in this case, the aminoglycoside, is superior to anything else, you may still need to use that drug and try to monitor the situation as good as it gets, because otherwise you will lose a patient to the infection. So we already touched upon voriconazole, and we learned that CYP2C19 polymorphisms result in significant pharmacovariability. In this case, you see on the left side the ultra-rapid metabolizers with the low levels, and on the right top side you see the patients with the poor metabolizer phenotype. And there is a considerable difference in drug exposure between these various polymorphisms. This is the same polymorphisms, only reflected in full PK curves. You see at the right bottom of this slide, and you can see that there is a significant difference in exposure and also in shape of the concentration time curves between the different polymorphisms. So there's some guidance issued regarding prescribing of the drugs in these polymorphisms. And also you can see on the right side the level of evidence considering that recommendations. So for all the polymorphisms, there is moderate recommendation to make changes to therapy. And in these there's ultra rapid metabolism, you're not likely to achieve therapeutic voriconazole levels. So switching to an alternative agent may be preferred. In some cases, in children, they do try to increase drug levels and do TDM because some of the alternatives may not be appropriate for children. For the poor metabolizers, of course, switching to another drug may prevent toxicity, but providing a lower dose in combination with TDM can do the trick as well. But of course, depending on your access to TDM, you may decide differently. So based on these polymorphisms, there are some interesting trials ongoing. In this case, they have prospective genotyping, and based on the genotyping, they have a dose decision for the various clusters of patients. And they use this fast array for genotyping, and they use an immunoassay for the TDM. So both could potentially be operated in substantial numbers of hospitals. So what we expect from such a trial, and you can see here a flowchart of the whole study procedure with patient selection, randomization, genotyping versus standard of care. You see that targets are, of course, comparable to what we do without genotyping as well. But when we look at the sample size 2 × 62, which is purely based on the expected effect of the genotypes, I have some doubt whether this sample size is sufficient to find a difference between the 2 types of dosing strategies. Unfortunately, there are no results yet, but hopefully they can complete the study by the end of this year. And what I mean with the influence of other effects, I allude to the effect of inflammation on voriconazole. We know that within severe inflammation, the CYP enzyme machine is affected. That could result in phenol conversion from an extensive metabolizer to a poor metabolizer. So in that case, your genotyping will not inform you correctly on the situation in the patient. So when we are moving onwards towards implementation of genotyping in the ICU, there are 2 main strategies. We can have preemptive genotyping. So we would like to have that genotype available before we start treatment or even before a patient enters the ICU. Or we could start with genotyping at the moment we want to prescribe a drug. So in the latter scenario, of course, turnaround time is key. Otherwise, a patient is either dead or has been discharged before you get the result. And in the first situation where you have those results readily available, you could consider including those informations in the EMR. And then it can function like a traffic light system as prescribed in this paper by O'Donnell and colleagues, informing you on the situation in that particular patient, and it could help you make different decisions in drug selection. So in this prospective study, they genotyped a whole cohort of patients who would receive elective cardiovascular surgery, but were likely to stay on the ICU for a little while. And when they looked at the results, you can see in the table below that there are a substantial number of poor metabolizers for 2C19 and 2D6. And there are a couple of intermediate metabolizers, but also fast metabolizers. So likely for some of these medications, there would have been relevant changes to drug doses made. There were in total 98% of the patients could have potentially had an actionable result. And of course, it remains to be seen whether a patient would have been prescribed a particular drug or whether that would have been necessary. But at least there were opportunities. And when we talk about the reactive genotyping, it's all about turnaround time, as already mentioned. So we really need looking for a point of care test or something that is really fast, like lab on a chip. But there are, of course, challenges, and that is because we need to extract DNA and amplify it before we can actually perform the measurements. And we have, of course, to distinguish between the different variants of the genes. And of course, that is a little bit different compared to showing the presence or absence of, for example, a bacterial DNA to diagnose a defection. So it is a little bit more challenging. And of course, we have our various methods of detection of our results. And last but not least, we have our quality control and regulatory oversight programs that need to make sure that these results are correct. So it's a little bit challenging, but I think with some time we will get there, at least for some of these more frequently observed genotypes. So we'd like to end with some summarizing thoughts. And the first one is the level of evidence for the use of pharmacogenetics in the ICU. As already started with my presentation, there's little evidence available at this moment. So the question is whether we can accept current evidence from non-critically ill patients, or we need to repeat all these randomized controls in the ICU. I think that would be a significant challenge because you need large numbers of the various genotypes to see the effect on treatment outcome. So I think this will be a very challenging situation for the ICU. If we look at what could be a successful implementation, I think we should focus on toxicity. If we know that there are specific genotypes that are associated with severe or irreversible toxicity, that may be worthwhile if we have a rapid test. Or for polymorphisms associated with treatment failure, like ultra-rapid metabolizers of 2C19 for voriconazole. The other situation is if we know the pharmacogenetic genotype of a patient, do we want to use that particular drug that is metabolized through that particular enzyme, or do we simply switch to a drug that is not subjected to that particular mechanism? And there are nice examples. Let's say we were so worried about voriconazole and 2C19 ultra-rapid metabolizers. If we just switch to isavuconazole, there's no issue at all. Of course, the issue with isavuconazole is that it's a little bit more expensive than voriconazole. So the decision in that case is still challenging. But I think we should consider using alternatives to be safe and fast in some of these situations. I think there's interesting opportunity for preemptive genotyping in special populations. And I mean patients, for example, transplant patients, especially the more severe transplantations like lung or heart transplantation. We know these patients will spend a little bit of time in the ICU. So if we genotype them before surgery, we know their particular genotype. And of course, if we are talking about liver transplantation, we need to genotype the donor and not only the recipient, because then we have the wrong genotype. So I think there are opportunities in that space to have those informations available when patients enter the ICU. And last but not least, with rapidly evolving technology, I think we need to reassess these point of care tests in a year or 2 years and see where we're up at that particular moment. And with that, I would like to end this presentation with a nice sunny picture of our lovely Westmead Hospital. Thank you.